an excellent presentation. It's my honor now to invite back Professor Mohamed Sayegh for the last presentation of this morning session. He's going to update us on the current status of a new approach to suppress the immune system against the allograft, involving the blocking of T-cell co-stimulation with biological. One step forward and two steps back.
This is the answer now, sir. Sir, this one. Okay, sir.
Thank you. Immunologists have known for many, many years, since the 1970s, although at that time we obviously didn't know the exact pathways, that in order for the T cell to be fully activated, it requires two signals. One of them is delivered by the T cell receptor when it recognizes antigen. Another one, which is called a co-stimulatory signal, is delivered by the interaction of a molecule on the antigen-presenting cell with the receptor on T cells. And while this signal alone does not deliver an activating signal to the T cell, it is necessary and important to result in full activation of the T cell. However, since then, this field has emerged dramatically over the last 20 years or so. In this review article in 2009, we summarized several of the new things that are known now about co-stimulatory pathways. First one is that not all co-stimulatory pathways are in fact positive pathways resulting in activation of T cells. Some co-stimulatory pathways inhibit T cell activation. In addition, there are very complex interactions among the different pathways. And very importantly, which is mostly the impetus behind this talk, is that the co-stimulatory signals required for different T cells may be different, but also some co-stimulatory signals that are important for T cell activation may be important for T cell regulation. And therefore, targeting co-stimulation may have different results depending on what you are targeting and when. And finally, a very interesting and important area that we are exploring is the expression of some of those co-stimulatory molecules on parenchymal cells, not antigen-presenting cells, such as the kidney or the heart or other organs, and what is their role in transplantation. This slide just shows you that there are now two important family of pathways, what we call the positive co-stimulatory pathway, that result in proliferation, differentiation, and development of memory cells. This is extremely important in immunity and in infections, obviously. And the negative co-stimulatory pathways, which is in a way like the endocrine system, a negative inhibitory pathway to control the immune system. And that is after activation, mechanisms occur that will inhibit the T cell and immune response. And if you don't have these mechanisms operational, you can develop lymphoproliferation or autoimmunity. Now, Ctla-4 Rg, as you all know, has now been approved for the treatment of both rheumatoid arthritis several years ago, and in addition, more recently, a modified version or a second-generation version was approved for the use in kidney transplantation. Now, what is Ctla-4 Rg? The CD28B7 pathway is perhaps the most important co-stimulatory pathway. It is a very complex pathway because it involves the interaction of CD28 on T cells with B7, 1 or 2, or let's say the B7 molecules on antigen-presenting cells. In addition, after the T cell gets activated, there is a molecule called Ctla-4, which is a negative inhibitory signal, also binds to B7 and inhibits T cell responses. And the affinity of Ctla-4 is higher than CD28. So in the presence of both, Ctla-4 wins and inhibits T cell activation. Now, Ctla-4 Ig is a fusion protein that competitively binds to B7 and inhibits the interaction of CD28. So what it does, it inhibits T-cell co-stimulation. This is an animal transplant model. If you transplant these animals and give them Ctla-4 Ig in yellow, there is long-term survival of our transplant. If you give them an antibody that blocks Ctla-4, which is a negative signal, so they are inhibiting an inhibitory signal, you result in a positive signal, which now accelerates graft rejection. If you take an animal that does not have CD28, they do reject grafts, but in a prolonged fashion here in red. However, if you take an animal that does not have any B7 molecules, they have long-term survival. This is a fully MHC-matched animal. So this is all consistent with our knowledge that CD28-B7 interaction delivers a positive signal. If you inhibit it, you get long-term survival, inhibit immunity, and Ctla-4 delivers a negative signal, and if you inhibit it, you will accelerate immunity or enhance immunity. Ctla-4 Ig, or Orencia or abatacept, as you know, was first tested in psoriasis, but then developed in rheumatoid arthritis and approved for the use now, and it's available on the market for the treatment of rheumatoid arthritis, and it is currently being tested in patients with multiple sclerosis and lupus. In fact, my wife, Dr. Samia Khouri, is the PI of the MS trial, and this is funded by the NIH. Now, T-cell co-stimulatory blockade with Ctla-4 Ig has been developed in the clinic, and I will show you some very interesting data that are somewhat surprising when you first look at them, but when you in fact tie it to the immunology of this pathway, you will understand why these results are not as expected. And that's why the title of the talk was T-cell co-stimulatory blockade, 1 step forward, 2 steps back. First, the Bristol Myers Squibb is obviously a very smart company, and what they did after approval of Ctla-4 Ig, they modified it a little bit and made a much more efficient or effective molecule in inhibiting B7, because the turn-off rate after binding to B7 is longer, and they made another molecule called belatacept, LEA29. Practically, it is a second-generation Ctla-4 Ig. It has a 10-fold more potent inhibition of T-cell activation in vitro. But in a way, this is somewhat meaningless, because on a milligram-to-milligram basis, you can achieve the same effect with the parent compound. But now they're going to end with 2 biological agents on the market. So you could get a sense, and these are very expensive agents. One is for rheumatoid arthritis and one is for transplantation. So the initial trial was, phase 2 was done by Flavio Vincenti, published in 2005. And what they did here is they compared a calcineurin inhibitor regimen with 2 regimens of Ctla-4 Ig to replace calcineurin inhibitor. One where the patients received an intensive course initially and then subsequently less intensive, and then a much more intensive course. So there are 2 different protocols related to the frequency of administration. Remember, this is a biological agent that has to be given intravenously to the patients. Come to the clinic, get an injection, and go home. And then later on be maintained every few weeks. And what they found in this study in 2005, that there was equivalent acute rejection rate, so it can replace calcineurin inhibitors. These patients were not taking calcineurin inhibitors when they take Ctla-4 Ig. There was improved GFR, obviously because they are not taking calcineurin inhibitors. There was, at that time, less chronic allograft nephropathy by biopsy. It was relatively safe, although there was a hint that some of those patients may develop lymphoma. And one of the interesting things was there were patients that were taking the agent, but they still had rejection. And biologically, if you think that you are blocking T-cell co-stimulation, you really should not have an immune response, similar to the animals that had no B7. Then in 2010, based on the initial phase 2 study, the company did phase 3 studies, which were the basis of the approval in two patient populations. First one is called the benefit study, which is in patients that were first transplant low-risk patients. And the belatacept regimen compared to cyclosporin demonstrated superior renal function, less chronic allograft nephropathy, similar patient graft survival, and a favorable cardiovascular metabolic profile. However, there were higher acute rejection episodes in the patients that received more intensive Ctla-4 Rg. That doesn't make sense, right? If you take more immunosuppression, you should have less rejection episodes. In addition, these patients had higher incidence of infections, particularly also EBV and PTLD. So you have a patient population that is more immunosuppressed, had higher rejection. Since when, as a clinician, you have seen patients that were over immunosuppressed and had increased rejection rates? Have anybody seen that? No. Typically, we learn for many, many years that patients who are over immunosuppressed, they have no infections or less infections. And patients who have infections are under immunosuppressed. This is a unique patient population that is more immunosuppressed, yet they have higher incidence of rejection. And you can see here that the more intensive belatacept protocol group had highest rejection rates as compared to the calcineurin inhibitor group. Now, certainly the calcineurin inhibitor had very low rejection rates, but still 22% in the more intensive protocol is not acceptable in these days to have acute rejection rates in the 20s. In the other study, the extended benefit group, this is in patients who were high-risk patients. And what they found out, high cold ischemia, etc., there was similar patient survival, better renal functions, very similar results, and there were similar acute rejection rates. In fact, there were not increased acute rejection rates similar. And again, this doesn't make a lot of sense, right? This first patient population is the low-risk patient population, and they had higher acute rejection rates. But in the higher-risk patients, they didn't. So the question is why? Well, we know, so we had to go back to the bench, and the company and the investigators was really confused. Why is this happening? And everybody, in fact, some of the investigators thought that these patients were under immunosuppressed initially because they didn't know, which protocol and which dose, etc. Now, if you, as I told you before, this pathway is also very important for regulatory T cells. So not only for effector and inflammatory T cells. The regulatory T cells are, as you know, physiologic T cells that express CD4, CD25, FOXP3, and they are very important to inhibit immune responses. And this is a paper published by Jeff Bluestone showing that the CD28 pathway is critical for the homeostasis of regulatory T cells. So when you block CD28b7, you are not only blocking effector T cells, but potentially you may impacting regulatory cells. So we then wanted to take a look back at this issue, and we transplanted, this is a model of a class 2 only mismatch. They survive long-term normally, no immunosuppression. If you take a CD28 deficient mouse or a B7 deficient mouse, which I showed you before, in a fully allogeneic, more powerful system, they have long-term survival. In a less incompatibility system, they in fact had accelerated rejection. Doesn't make sense, right? If you have a more incompatible system, this agent or the blockade or the absence of these molecules should be less effective. This is a less incompatible system, only class 2 difference. Normally they survive long term. When we blocked B7 or removed it or removed CD28, they had accelerated rejection. And in fact, you can look at the pathology and find out that they have severe rejection, and it's not something else that's causing the destruction of the graft. But what was very important is these animals that don't have CD28b7, they have severely reduced number of regulatory T cells. And the effector memory T cell ratio to regulatory T cell is significantly increased. And you can look at FOXP3 staining for these regulatory T cells, and they are very scarce in the animals that have no CD28B7. Now, if you remove these regulatory cells by anti-CD25, it has nothing to do with co-stimulation, you get exactly the same result in these animals. You get accelerated rejection. So what we think is happening is the absence of CD28 co-stimulation is exactly the same as removing regulatory T cells in these animals. And the same thing if you give anti-B7 antibodies, like the knockout, there is accelerated rejection. So again, you are blocking CD28B7, resulting in accelerated rejection. And you can, very interestingly, look at the various animals that I have shown you, and the lower the number of regulatory T cells, the shorter the survival time. These are the normal animals. They survive long term, and you can see here, the lower the regulatory T cells, the worse the survival. So from these studies, what we have shown that the absence of CD28 co-stimulation or blockade with antibodies in this particular less incompatible model, which we expect that they will survive long term, they in fact had a paradoxical worse rejection rates. We then recently moved, and this data has not been published yet, it is new, to actually use Ctla-4 Ig in these animals. And as I showed you before, if you take a fully incompatible model and you give Ctla-4 Ig, they have long-term survival. If you give Ctla-4 Ig to a normal animal, they have reduction in their regulatory T cell. And when we gave it to this MHC to mismatch model, which we do expect that they will have much less incompatibility, they had accelerated rejection. And what is even more interesting, if you delay administration of Ctla-4 Ig, at any time post-transplant, you precipitate rejection. This again doesn't make sense, right? Because you think that Ctla-4 Ig should inhibit rejection and block T cell co-stimulation. But what is it doing in this model that is dependent on regulatory cells? It's decreasing regulatory T cells, tipping the balance and affecting and causing rejection. However, if you compare it to a fully allogeneic, very powerful system of incompatibility, in fact, it prolongs graft survival. Remember, in humans, the benefit study, low risk, Ctla-4 Ig increased rejection. In the extended benefit study, high risk, it in fact did not increase rejection, which was very paradoxical from what we expected, but it's very similar what we are seeing in animals. It also showed evidence of increased alloreactivity. We can measure, in fact, that in the animals treated with Ctla-4 Ig, there was increase in the cytokine production by their T lymphocytes, but it did not affect the regulatory T cell function. So, if you now want to look at the humans back and try to understand and explain why these patients that had received Ctla-4 Ig had increased rejection rate, yet they were immunosuppressed, I think it becomes relatively easy to understand, but it makes it very complex of how to treat patients with Ctla-4 Ig. So if you take a donor-recipient combination that has a small alloreactive T cell pool, such as a living donor, transplant, first transplant, low risk, normally these people are the easiest to immunosuppress, right? But in this case, if you give them high-dose Ctla-4 Ig, you inhibit a little bit the alloreactive T cells, but you dramatically also affect the regulatory T cells. And in these patients, regulatory T cells are very important. You tip the balance, and they end up having rejections. Now, of course, not every patient does this, because the balance is very tight. But in patients who see this problem, tipping the balance of regulation, they will reject. So they are immunosuppressed because you are inhibiting their alloreactive T cells, but they also have reduction in the regulatory T cells, and therefore they reject, but they also have infections and lymphomas, which is a very unique combination in a patient. If you take a high-risk patient where there is a large alloreactive T cell pool, cadaver, highly mismatched, ECD, kidney transplant, what happens when you give high-dose Ctla-4 Ig? You drop both but you dramatically drop the effector T cell pool, and that balance results in protection from rejection. Very similar to the fully mismatched animal model. In the fully mismatched animal model, when we gave Ctla-4 Ig, it caused long-term survival. But in the lower incompatibility MHC mismatched model, in fact, giving Ctla-4 Ig was much more deleterious. And finally, and very interestingly, in a subsequent study that's still ongoing that was presented last year at ATC, if you combine Ctla-4 Ig with thymoglobulin or with a T-cell depleting agent, you didn't see that increased acute rejection rates. The reason is because, and this is combining different groups, showing that there was no differences in the acute rejection rates here. Very similar among the groups. So now you are combining a T-cell depleting agent with Ctla-4 Ig. And the reason is very easy. Because thymoglobulin spares regulatory T cells. This is a paper we published a few years ago, that when you use thymoglobulin or T cell depleting agents, they do inhibit effector T cells, but they don't also deplete regulatory T cells. So now, or in fact, enhances the conversion of regulatory T cells. So now you have a nice combination of a T cell depleting agent, which inhibits alloreactivity dramatically, and Ctla-4 Ig, but thymoglobulin is allowing you to spare regulatory T cells. You mitigate the effect of the increased acute rejection rates. And Chris Larson is doing a similar study, but using Campath instead of thymoglobulin. Now it has not been done. And this is the protocol they are comparing. And this is the study by Stuart Connectley also showing that Campath spares regulatory T cells. So if you go to the model that I described to you, now you have Ctla-4 Ig in combination with T-cell depleting agent, and you have a small alloreactive tool. You dramatically inhibit the effector cells, and you spare regulatory T cells, which results in protection from rejection. And therefore, the combination of T-cell co-stimulatory blockade with something to spare regulatory T cells, such as thymoglobulin or rapamycin or other things, is going to be necessary in order to prevent the deleterious effect of blocking T-cell co-stimulation on regulatory T cells. So I will stop here and be happy to take questions if time allows. Other studies that are going on results in the conversion from patients who are taking calcineurin inhibitors. These are still early, but have some positive results indicating if you convert to co-stimulatory blockade, you may not see that increased acute rejection rate. Thank you very much, and I will stop here.
5 minutes for question. Any question from those? Yes, please.
I have a question for Professor Sayegh and another question for Dr. Mashari. I'll start with Professor Sayegh. Congratulations for this elegant presentation as usual, Dr. Mohamed. I have an impression, but I would like to take your opinion. During your talk, I have the impression that with immunosuppression, with the new advances of more and more immunosuppression, we are very glad with lesser incidence of acute rejection, but on the expense of the chronic allograft dysfunction, with more infection as BKA, BK nephropathy, and others that we don't know, as well as more transplant vasculopathy, for example. What's your comment?
You know, I don't know if there is a direct correlation or a cause effect. I think what is happening when we target a particular pathway of the immune system is extremely smart and very redundant, and it adapts. And the reason is because the immune system, as you know, has evolved to protect us from infections. So anytime you want to suppress the immune system, it finds a way to escape this, because the survival of the organism depends on fighting invading microorganisms and infections. So for example, I mentioned to you the situation with IL-17. When you inhibit interferon gamma T cells, IL-17 comes up because IL-17 is important in inflammation and immunity. Same thing is when you disturb the balance by using agents such as Ctla-4 Rg, where there is an impact on regulation, you'll end up having an infection. So I think what is happening is not that when we use immunosuppression and inhibit acute rejection, you end up with chronic rejection. It is that anytime you target pathways with some unique immunosuppressive medications, what is happening is the immune system is much smarter than us, and it tries to adapt by developing mechanisms that will allow protection of the organism, which is the human receiving those immunosuppressive drugs, and therefore you end up with what we call untoward results. I think the goal of our investigations is to try to find the balance of using sufficient immunosuppressive drugs, target pathways in combinations that allows you to prevent acute rejection, prevent chronic rejection, and at the same time not expose the patients to over-immunosuppression. And this is not easy, because you really want to try to change the whole immune system in a way. But it's not impossible. It is something that can be done, but it obviously is a tight balance. Everything in life is a tight balance, specifically in the immune system. And there is always a price that you have to pay. Even as Dr. Mishari mentioned, you can prevent AMR with very heavy-duty guns, but you're going to pay a price with infections. So what do you subject your patient to? Do they lose the kidney from acute antibody-mediated rejection, or they lose potentially their life from infections? And again, it's a tight balance. So I think, the more we learn, the more we are becoming smart, at least at understanding how the immune system adapts. And hopefully this leads to smarter combinations that will allow you to be able to use them without subjecting the patients to really serious problems. But there's nothing called a safe immunosuppressive protocol. I mean, just does not exist. There is always a price you have to pay.
Okay. I would like to take your opinion about the percentage. If you can bring me a number for the immunological factors and the non-immunological factors as a cause for CAN, chronic allograft nephropathy. How many percentage for this immunological and how many percentage for the non-immunological?
It's honestly very tough to give percentage, because it may be different in different patient populations. Somebody who has CMV, somebody who had a very ischemic kidney, etc. But overall, I would say that the predominant mechanisms that cause chronic rejection are immunologic and antigen dependent. The others basically contribute. Now, if you take one patient in particular that has severe ischemia and has CMV and got a bad organ, probably the reason they develop chronic allograft dysfunction because they had a bad organ that is injured, plus immunologic injury. But if you take another patient, then the story may be different. But if you want to look at a population, then without immunology, you don't get rejection. I mean, this is a simple answer, really. If you don't have immunologic injury, you cannot reject a transplant. Rejection, by its definition, is mediated by immunologic injury. Yes. Yes.
Last question, please.
Thank you very much, Dr. Sayegh. I really like the explanation you gave for a very difficult question. My question, do you have data from the CAMBAC and RATG trial whether sparing the Treg resulted in less PTLD or no?
No. Well, I only know from the CAMPAS study is still ongoing. The CTLA, the THIMO was a 1-year, again, preliminary report that was mentioned in ATC. To my knowledge, they have not seen more PTLD in that group, which is very interesting because this is a much more immunosuppressive group. You would think that if you add a T-cell depleting agent, you should see more PTLD because there were more immunosuppressed, and that's not the case, which tells you that it is really a very tight balance between regulation, etc. The problem, with these studies is they, at least in the big phase 3, they have not looked at the regulatory T cells. We are now doing a comprehensive study where we are looking at regulatory T cells in these patients, etc. And I mean, We are trying to correlate what we find in animals to what's happening in humans. It will be nice to do this in humans, obviously, to prove the point. But there are some evidence to suggest that that is the case. We don't see PTLD, which is very interesting.
Dr. Nabil.
Yeah, Dr. Mohamed and Dr. Khalid, thank you very much for the beautiful talk. Well, it's just coming to mind. Now we are seeing patients coming after many years, and chronic rejection is becoming more or less established. I was just thinking, after all this, if we give patients every 5 years an ATG course or something as a boost, do you think that's a good idea, or just an imagination? The other thing is, chimerism used to be talked about a lot, and we don't hear anything about it. Is that abandoned now? Thanks.
Let me address the first question, which is related to thymo. I don't know if anybody has done this, and I don't know what it would do, but we have done a study in animals and small animals and now in primates, and we have an approved study with Genzyme to do it in, previously Genzyme, to do it in humans, where we looked at because of that paper that I showed you, that thymoglobulin in fact or results in increased conversion of regulatory T cells, we did a protocol where we gave animals low dose, non-depleting or not completely depleting thymo chronically. So not just induction, but we continued. And in a very, very tough model of transplantation, skin transplant, we showed that these animals have long-term survival. And the reason is because they have sparing of their regulatory T cells. So one could envision a protocol that you give patients low dose chronic, and the low dose we are talking about is 10 to 25%, which does not deplete T cells completely, but spares regulatory T cells. You can give them for 6 months is the protocol we proposed of low dose continuous thymoglobulin to allow sparing of regulators with long-term outcome. And whether boosting every 3 months or 6 months or a year, etc., will have an impact because of this effect on the regulation is a very interesting question. It hasn't been done. We did that in monkeys, and it showed the same results that we saw in mice. The chimerism story is a little bit obviously complicated, but you have to differentiate between chimerism and microchimerism. Microchimerism is pretty much dead in the sense that the Thomas Starzl observations that patients who have donor cells, very small number in the recipients, they are potentially could be tolerant. We don't think there is a cause and effect. We think that patients who have donor cells in their periphery are probably tolerant, not because of those cells, but because they cannot reject them. So it's just an epiphenomena. Although nobody has proven the principle, if you get rid of these cells, you reject the graft. However, on the other hand, the large animal studies and the studies done by Mass General with bone marrow transplantation with an organ to create what we call macrochyme, and to replace the bone marrow to some extent of the donor, or create a state of mixed allogeneic chimerism of donor and recipient, results in tolerance is true. And as you know, they have published a paper a couple of years ago of 5 patients, 4 of them were tolerant. And in addition, they are doing a larger study now. Interestingly, the one patient that was not tolerant, rejected and lost their graft, developed antibody-mediated rejection because the protocol does not affect B cells. So that chimerism part, which is the mixed allogeneic with bone marrow from donor and recipient, is a very viable strategy. But again, there is a price to pay. But the microchimerism story is, at least for now, pretty much dead.
Thank you very much.
So thank you.
Thank you, Dr. Mashari, and we'll go for coffee break and then come back. If you have many more questions, maybe during the coffee break.
Can I have a question for Mashari, please?
During the coffee break, please.